In the spirit of reconciliation, DHSV acknowledges the traditional custodians of the land that we are filming on and their connections to land, sea and community. We pay our respects to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples today. Welcome to the DHSV Coffee Catch-Up series, where we shine the light on key oral health issues and spark discussion that leads to change. If you work in the health sector, you've likely heard the term value-based healthcare a lot. But what exactly does it mean? In short, it's about improving the health outcomes that matter to patients in a cost-efficient way. Health systems around the world are struggling to meet the demands of population growth, an ageing population, rising rates of chronic disease, high consumer expectations, and increasing costs of providing care. We can't keep forging ahead the way we always have. We need a new and more efficient way to drive health outcomes and improve the experience for patients. At DHSV, we started developing our value-based models of care in 2017, and it has completely changed our approach to improving oral health. Someone who is a big part of that transformation is our former board chair, Prof Zoe Wainer, who is here with me today. Zoe is the Deputy Secretary for Public Health in the Victorian Department of Health and has previously held roles as the Director of Clinical Governance and Head of Public Health at Bupa Australia and New Zealand. Zoe holds a Bachelor of Medicine and a Bachelor of Surgery from Flinders University and has a clinical background in cardiothoracic surgery and thoracic surgical oncology. She has a PhD and a Masters of Public Health from the University of Melbourne, is a Fellow of the Australian College of Health Service Management, and is a graduate of the Australian Institute of Company Directors. Zoe is also an Enterprise Honorary Professor at the University of Melbourne. Morning Zoe, thank you for joining me here on the couch. Today we're going to talk about all things value-based healthcare. Just to start off, how do you think value-based healthcare is actually going to improve the healthcare system in Australia?
Well, so I think, as we've discussed before, there's many principles or elements of value-based healthcare that are not new to begin with, and I think it's important to recognise that. Certainly when we have conversations with experienced people in the healthcare system, they can recognise those principles that are fundamental to quality improvement and safety. I think what it brings in, which is novel, is also what we know works in business when it comes to understanding competition theory, how incentives work, but really importantly, of course our system is always patient-centred, but it actually speaks to principles of designing the system around the patient, which is quite a different approach. So I think and also I would add in the Department of Health, we're really quite focused at the moment about how value-based health care can also improve populations. And so not just thinking about patient-centric in that numerator, but also thinking about community, outcomes that matter to community and to populations more broadly, and that really brings in a strong equity lens. I think the other areas that we're working in is also around exploring the denominator and broadening the concept of costs, so that costs just don't refer to finance, but also to emissions and other elements of impact from a cost perspective to the system more broadly.
Looking at that from a practical point of view, how do we actually get the data that we need to actually show the outcomes that we're looking for, but also, if we're going to broaden the denominator and look at broader costs, has the department thought through what that might look like into the future and how we would go about that?
Well, I think as you and I both have experienced, one does not wait to get perfect data systems before you start on this journey. So I think it's starting very much with the principles around what that cost could and should mean. We are actually doing a lot of work in the department to really think about how you capture environmental impact from healthcare. Obviously in public health we're often more the recipient of the challenges of climate change more than the emitter, but obviously the health system more broadly is a significant emitter. I also think that the value of that equation in value-based healthcare is often not the literal application of it. It's actually having it in the back of your mind all the time, thinking, am I improving value using that numerator and denominator in the decisions I'm making every day. So it almost frames a decision making framework more than a literal equation to be implemented.
I would agree. I think we've really struggled with looking at that equation literally at DHSV. How do what outcome are you actually measuring and what costs are you actually measuring? And I think you're right. I think it's the real key driver to improving health outcomes is actually understanding those outcomes that are important to patients and how we actually measure those, and actually what does that mean, as you say, from not just an individual level but from a population-based level as well.
And I think there's an element to the numerator when we talk about outcomes that matter to patients that's really resonates in some of my conversations with ACHOs as well, because it deeply speaks to self-determination.
Yeah.
This is really about the outcomes that matter to community and populations, and that's not up to me in the department to decide at all. And so if we can empower our communities to articulate the outcomes that matter to them, I think that will also really improve equity in health outcomes for populations and communities.
Yeah, I totally agree. What do you think are some of the ways that we can actually, because we know in the work that we've been doing at DHSV, this takes a shift, a cultural shift, not only from our clinicians' point of view, from our organisation as a whole, but also from the community and what their expectations of a health system look like. How do you think we can actually improve communities' understanding of this, and how they can actually, that co-design piece, the shared decision-making piece, what does that look like as we move forward, do you think?
Well, I think the real importance in the co-design is starting at the right point, which is defining the problem.
Yeah.
And that needs to be done together, because what the Department of Health might think is the problem is not always reflected in what the community experiences the problem in the moment. And so the fundamental elements of each step in the direction of defining the problem and then providing the solutions has to be done together with equal and equally valued voices. I mean, certainly my experience in value-based healthcare is when people have enough time to really embrace it and engage with it, it's deeply rewarding for clinicians, because it's actually what they got into healthcare to do. Yeah. And it's giving them the tools at the front line to understand the cost, to understand the outcomes, to see the opportunities for improvement, and to implement that themselves. Not wait for you in the CEO suite or me in the department to be dictating what that looks like, because that doesn't actually lead to better outcomes either from the clinician's perspective or the communities, but to co-design with each key stakeholder in that value chain and patient journey.
Yeah, I totally agree. Do you think that, I guess, what's changed in the value-based healthcare conversation or thinking in, we started this journey, or you started this journey at DHSV back in, 2015-16. Has it shifted much, or is it still the same principles and concepts, or have we actually tweaked them a little bit, do you think?
So certainly think the thinking is evolving. I think the principles and framework are holding up relatively robustly, although as we've explored earlier in our conversation, there are, I think, evolutions in the thinking around what the denominator might look like, what the numerator might look like in that value equation. And as we said, that's not a literal equation at times. It's really a framework to make decisions through. The evolution, in addition, that I've seen is outcomes that matter to patients. Sometimes having a disease-specific approach is not always the best one.
Yeah.
It really, many people will have multiple chronic diseases, and if we're taking outcomes for each of them, it gets quite complex in understanding what those outcomes are. So I think there's been a lot of work done by Professor Teisberg and her team around calm, comfort and capability as a way of really wrapping the outcomes around the patient or the person who's going through a health journey. And then I think the other elements in the evolutionary thinking that I've seen is really bringing in that population and community health lens.
Yeah.
So that this isn't always about an individual patient when we think about health outcomes. We need to lift it to the broader population lens as well.
Yeah, totally agree. Just going back to Elizabeth Teisberg's work in relation to outcomes and capability, comfort, calm, we're reasonably good, I think, in looking at outcomes in relation to capability, and reasonably good at looking at outcomes in relation to comfort. I don't think we're so great at looking at outcomes in relation to calm. Do you have any thoughts and ideas on how we could, frame that better, or what does that mean for people?
I'd almost push that back to you, Sue, but it is a great question. I think we're very biological in our model.
Yeah.
And that's important. But actually, when I look at the metrics and how people think about outcomes, I'm always interested in how people break out PROMs, PREMs and clinical outcomes, because I actually think they're a Venn diagram. I think they're intimately related with each other. And I think that goes to your point about how do we start thinking about the calm element of it and the impact that chronic disease has on people's experience of their daily life, and then how do we measure that and understand how we improve it. I think it takes that holistic perspective of a person or a community's journey in their healthcare, but moving away from a purely biological model. You know, we often have this debate a bit internally around mental health. It's really important. We have a division and department that's dedicated to mental health, but at the same time it also keeps it kind of separated from health more broadly. And how do you get that balance right of ensuring it gets the focus and attention that it needs and deserves for Victorians, but equally ensuring that we're not actually creating a false split between body and mind and emotions and experience. And that's why sometimes I'm a bit challenged when we talk about clinical outcomes, PROMs and PREMs, because I just think I'm not confident that that split is helpful.
I'm wondering, you know, does it go from a Venn diagram to a diagram that's actually got four quadrants in it, and that fourth quadrant is about system efficiency and effectiveness that actually enables, you know, end-to-end processes for patients that are, you know, simple and easy to navigate and, you know, effective, rather than, you know, we've all seen the patient that bounces from one clinician to another and gets lost in the system, and, you know, it doesn't matter who you talk to that has had either a chronic disease or even acute episode. Trying to navigate a system is extraordinarily difficult because it just, nothing seems to line up, particularly, you know, we've got a public system, a private system, you know, different parts of the organisations don't talk to each other, those sorts of things. I wonder whether there's a massive piece of work to actually try and get that calm piece a bit more sorted.
Well, I mean, the first observation I would have is something Professor Tom Feely, who's one of the original people who did a lot of work in value-based healthcare, particularly in the cancer space. He said the moment you need a navigator, you don't have a system.
Yeah. Totally true.
And I absolutely agree. I have this reflection myself. If you look at primary community care, private health, and let's say tertiary public health, no one stakeholder in the healthcare system has visibility over that patient journey. Or the costs, or the outcomes, or the experience. And we need to do something about that, because that's actually not okay. We really need to be able to support people on the journey so that it's less about navigation and more about a system that's genuinely operating at a system level. That means that the system is wrapped around that individual, rather than an individual needing to, as you say, navigate. I mean, I'm always mindful that we have a healthcare system that is really designed around what clinicians have studied rather than what patients experience. So if you present to an emergency department with chest pain, chances are they'll rule out cardiac. If it's not cardiac, they might probably send you home. You're still left with the problem, aren't you? And as you say, you then have to navigate that system yourself as a patient to try to work out what's going on, because we haven't actually designed our system around what that patient or that person's actually experiencing. Again, it's really more, we've designed it around what clinicians train in. There's some great examples from America where they developed a back pain unit. I think they saw a drop in MRIs of 21% and better health outcomes. I think there's a good example in Germany where they set up a headache clinic, and again they saw return to work significantly increased, because that fundamentally meant you needed everybody involved in that patient's care at the table making the decisions, and ideally the patient with them if possible.
And I think that's, you know, one of the key lessons I think that we've learned at DHSV in relation to building a value-based framework is that co-design piece with the patient, and making sure that everything we do, they're there helping us solve the problem. And we've learned a lot of lessons along the way in that space, but I think, you know, if we do nothing else, if nothing else comes of this other than the fact that we're actually involving our consumers and community in how the system should be built and what we should be doing, I think even that will be a great step forward.
And I'm mindful that sometimes people say, oh, value-based healthcare takes too long. You know, I think we've seen the work that DHSV's done in the drop to fail to attends, where you're actually getting an immediate investment opportunity as a consequence of decreasing those fail to attends. I think we've seen Catherine C's work at Northern Health, where again it was almost an unintended benefit, but the health literacy and the patient activation factor gave the clinician so much more information to understand how to communicate better with their patient, that led to better health outcomes outcomes, but also greater clinician engagement, because they actually found that's deeply beneficial to have that information. So they knew, rather than feeling frustrated about, why isn't a patient adherent to the treatment, they could actually understand where the barriers to understanding that treatment was, and therefore change how they were communicating to get better health outcomes.
Yeah, I had a fabulous conversation with Dr. Kenny Cole in Ochsner Healthcare in New Orleans a couple of weeks back, and he's based his entire clinic around the value-based healthcare principles, but he does a lot of work in diabetes and obesity, and they shifted their entire language around the way they were working with patients. It's not that the patient wasn't compliant, it's what did we not do to actually activate that patient or enable that patient to follow the treatment plan or the interventions that we'd actually, or the non-interventions that we'd actually laid out for them. And they've shown some absolutely amazing changes in outcomes for their community. So you're right. I think it's how do we look at why do people not do what we've set out for them to do, and how do we change, not how do we make them change, which I think will be interesting for some of our clinical colleagues to wrap their heads around.
But as you and I both experienced, when they do wrap their heads around it, they actually get really excited.
Totally, yeah.
There's an understandable change resistance, I think, particularly for more senior clinicians who've been doing their job the way they do it for a very long time, and genuinely contributing to the health and wellbeing of their community. So I understand the change resistance, but equally I think they, when they embrace the change, they actually find it deeply rewarding.
And it gets back to that, and that's one of the things that Kenny was talking about, is that joy in work returns for people, and you get much greater engagement of your clinicians, you get much greater engagement with your community, and people can actually see, and it's palpable, is his precise words, it's palpable to see the difference, which is, what we're trying to do. If you could wave a magic wand, it's a bit of fairy dust, what would you see as the ultimate outcome for Victoria and the public health system in the next 5 years?
There's a few elements to that. I mean, I think we know financial sustainability is a challenge for health worldwide. We're no different. We've obviously experienced a pandemic like the rest of the world has, and I think what we've seen through the pandemic is how it has exploited every crack there is in equity in the system. So how do we learn from that, and how do we embed that in how we design the system moving forward? I get a real sense of excitement actually in the Victorian health system when I talk to people about value-based healthcare, and maybe that's partly because I know I'm passionate about it, but there does feel to be a fundamentally different level of engagement with the system about recognising that we can do it better, that the system is struggling, and it's not, as I said, that's not a Victorian issue, that's a global issue with health, where we're seeing when we used to be able to make incremental changes improve a system, I think we're out of incremental fairy dust, so to speak. So I think if I was to be able to wave a wand, it really would be, how do we scale the experience of somewhere like dental health services? How do we understand why that was so successful? Equally recognising, I know that the organisation's still on a journey, and that's the point of value-based healthcare. You're always on an improvement journey, you never stop. I think we've learnt some really valuable lessons about how DHSV is structured that made it easier in some ways, not saying it was easy, but easier in some ways, and how do we therefore replicate that and lift that up to the whole of the system? And that in part goes back to one of our previous conversations around the fragmentation in the system along the payment models. So one of the things that we saw in Victoria was the standing up of COVID positive pathways. So this was a clinical pathway that really had the aim to provide the right care at the right time by the right clinician. And so one of the really innovative approaches I saw in that, or perhaps profound approaches that was different to other situations that I think we could lift to a whole of system, was we defined the outcome we wanted for the patient, we defined the outcome we wanted for the clinician and the system, and then we designed the care based on those outcomes with appropriate triaging, and then we worked out who paid for it. So rather than pushing people into traditional, almost combative relationships around payment, we actually focused on the patient and the clinician and the system outcome first. And then everybody came to the table with that kind of generosity and outcome in mind, and it made it a much easier conversation around the funding elements. Whereas, in many other settings in healthcare in Australia, we have real fragmentation based on the funding mechanisms.
Yeah, and I think that's right. One of the things that we did at DHSV in the very early stages was design the model and then figured out whether we could actually fund it. And we have shifted the way that we fund some things to actually, incentivise the way that we want the model to work. Still not perfect and a long way to go, but there are ways that you can actually do that. But I agree with you. You need to start with the outcomes in mind and how you're going to deliver the service, and then worry about, okay, well, how does that get funded and what does that look like?
And I think the other fundamental, if I could wave my wand in 5 years, is for us to not think about cutting costs in healthcare, but think about wiser investment.
Yeah.
So how do we think about every single precious dollar we have being invested in the best health outcome we can achieve?
Yeah.
And reassure our clinicians. I mean, of course, it's challenging financial sustainability, as we said, globally, but reassure them that these processes are not about cutting costs. It's about empowering them at the front line, because they know the best and wisest approach to investing that dollar to get the best health outcome for their patients.
Yeah, fantastic. Thank you, Zoe. Thank you for joining me on the couch. It's been a pleasure having a conversation with you, and I look forward to what the department's going to deliver in the value-based healthcare space as we move forward.
Thanks so much for having me.